So I just checked my clock and it's 5 o'clock, so it is time to call our meeting to order if everybody can hear me. This is the Knox County Board of Health meeting, September 23rd, 2020. And first order of business is a roll call. So Narda, if you can go through a roll call of board members for us, please.
Yes, sir. Dr. Drake,
Here.
Dr. Gotcher,
Here.
Dr. Hurt,
Here.
Dr. Mayor Jacobs.
Here.
Dr. O'Brien,
Here.
Dr. Shamia,
Here.
Dr. Sousa,
Here.
Ms. Wagner,
Present.
and Dr. Buchanan.
President, now we'll turn my camera on shortly.
Thank you.
Okay, so
Everyone and accounted for.
I think we have all members present, so we've established a quorum. And the next order of business, if we are ready, is a talk or discussion from Knox County Commission Chair Larson Jay. So Commissioner Jay, if you are on the line with us, we would appreciate comments.
Dr. Gotcher, I received a phone call from Commissioner Jay earlier today. He is not going to be able to join us, but he wants to know he supports our work, but he's not going to be able to join us. So I just
Okay.
found it out late this afternoon, so I apologize for not letting you know until now.
Not a problem, not a problem. So we will forego that right now. Perhaps he can do that at our next meeting. And the next item of business is approval of the minutes from the September 16, 2020 meeting. And I'll start by just saying in general, if there are any concerns, additions, or corrections that have come up, and if not, I'll accept a motion for acceptance and a second, please.
I'll motion to accept.
Second.
On a second. Any discussion, any changes, corrections, additions on the minutes? Hearing not, Narda, if you will go through a roll call vote for us for approval of the minutes.
Certainly. Dr. Drake,
Yes.
Dr. Gotcher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
Ms. Wagner,
Yes.
and Dr. Buchanan.
Yes.
9-0, sir.
All right, thank you. The next item of business on the agenda is to set the agenda, and you should have before you either printed or electronically the agenda for the meeting this evening. And just in general, any comments about that? If not, we'll accept a motion for approval in a second.
I'll motion to approve the agenda.
I'll second.
So we have a motion and a second. Any discussion on the agenda? If not, we'll vote for approval. Any discussion on agenda? Okay, Narda, if you will go through the roll call for setting the agenda, please.
Certainly. Dr. Drake,
Yes.
Dr. Gotcher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
Ms. Wagner, Ms. Wagner,
Sorry about that. Yes.
okay, and Dr. Buchanan.
Yes.
9-0. Thank you.
You have accepted the agenda for this evening. So the first order of business, I guess the next item on the agenda is item 7, which is Knox County Health Department benchmark presentation from Dr. Buchanan. So Dr. Buchanan, you have the floor.
Thank you, Dr. Gocher. I will let Charity pull up the data, and for some, once again, my talking points are out of order, or I'm missing a page, actually. So hold on one second. I printed it, but can you, yeah, okay. So I tell you what, we'll go out of order so Kelsey can print my talking points. I apologize to everybody for that. So we'll start with our third benchmark. Keep you guessing, Charity. So that's sustained or increased public health capability. For this benchmark, we aim to initiate investigations for new cases within 24 hours and close contacts within 48 hours. We have added 12 new team members into our EPI support team from last week. With this team, we continue to initiate investigations in our desired time frame. Because of this, our benchmark continues to be represented as green. Our fourth benchmark, healthcare system capabilities remain within current or forecasted surge capacity. During this time frame, no consecutive flags were detected. After speaking with the hospital partners, they stated their benchmark should be represented as yellow. So during the current time frame, no consecutive flags were detected. And Dr. Shamiya may speak more to leaving that benchmark at yellow at this time when he talks, I believe. Was that correct, Dr. Shamiya?
I certainly can address that, yes.
Thank you. Our fifth benchmark, sustained or decreased COVID-19 related death rate for identified positive or probable cases. Over the past 2 weeks, 9 people have died related to COVID-19. The information available leads us to represent this benchmark as yellow for another week at least. Here's Kelsey. Sorry everybody. So sorry for the door too. So go back up real quick and do the current situation. We had 55 new cases today. We have a total of 9,340 confirmed cases since March. Additionally, we have 407 probable cases. 7,902 of our cases are considered inactive, giving us 1,768 active cases. 345 individuals have been hospitalized at some point in their illness. 33 Knox County residents are currently hospitalized, and we did have one of those deaths was reported in the last 24 hours. So we have a total of 77 deaths. So, and then now we'll move on to our first benchmark. Sustained reduction or stability in new cases for 14 days. We've seen 2 red flags, but not on consistent days. Overall, the data indicates statistical decreases and is trending in the right direction. On average, we are seeing 116 new cases a day. Because of all of these factors, we are representing this benchmark as yellow. Our second benchmark, community-wide sustained and increased diagnostic testing with consistent or decreased test result turnaround time. Over the 14-day evaluation period, we did have 3 days of yellow flags noted regarding lab turnaround time, but not on consecutive days. The average turnaround time remains around 2 days. Regarding testing overall, the number of tests conducted continues to trend up, but there is a slight downward trend over the last few weeks. Some red days were noted, but those are on weekends when testing is not as widely available in the community. Over the past 14 days, there have been an average of 562 tests done in Knox County per day. You'll note that the state actually says there are more tests done in Knox County than we do. And again, that's just some differences in our data and how we pull that data. We may be transitioning to using that data in the future, maybe even next week, just for some consistency's sake. Since we're also talking about using the percent positivity rate, which is based on state data. Even so, we still have, even with that, we are still concerned about people not getting tested when they should. And to effectively evaluate this benchmark, we're planning on really honing in on this data for the next 3 or 4 weeks, determining where the trend is, if it's consistently going up or if it is in fact decreasing. For the time being, because of that factor, we are representing this benchmark as yellow. Our current present positivity rate, based on the Tennessee Department of Health data, is 8.2%. We are working on getting that data up on our website in the near future so people will be able to see that. If you recall, though, our positivity rate last week was about 12%, so that's down. But again, we've heard anecdotally, and we do have concerns that people are not seeking testing because they don't want to be in isolation and they don't want others to be quarantined, and we are very concerned about that. Our third benchmark, sustained or increased. Oh, I did that one already. So there we go. Any questions about the benchmarks? Do we have the other data, Charity?
Oh, yes. I can pull that up, sorry.
So last week we shared data about age groups and, which age groups are we seeing the most cases in, and we have some more. We have that data again this week, and Charity is pulling it up for us. So here you see the 5 to 10, the 11 to 13, and the 14 to 17 8-year-old age groups.
Schools there.
And so, yeah, so those are the schools. And as you can see, a lot of our cases are in those older high school grades, fewer cases in middle school and elementary school. Not terribly surprising. Then if we look at the next slide, please. This breaks it down to all of the other age categories, and you look at the 18 to 22-year-olds on the top there, where we saw that big surge. Those cases have come down. We hope that that's a trend that continues. I know UT is hopeful that that's a trend that continues as well. Any questions about this data and the age ranges and what we're seeing? Okay, thank you.
Thank you, Dr. Buchanan. Next on the agenda is the University of Tennessee Medical Center Knoxville data update by Dr. Shamia. So Dr. Shamia, if you have your slides ready, we'll get you started.
Okay.
They're coming.
They're coming. Okay, thank you. So I've got another agenda item later, and I'll have some data to show for that, but that is really for a different purpose. But I do think that will build on my standard presentation. So for example, Dr. Buchanan, part of my answer to your question about the hospital capacity, I'll give now. And then I think the other part of it, there's a particular slide that I think will complement as well. But I think for right this minute, let's go through the standard presentation that will also set the stage for a metrics discussion a little bit later. Next slide, please. So not to belabor this point, just that the correlation between hospitalizations and new cases persists both in Knox County and in the district. Next slide, please. So as far as the pace of new cases on Knox County, that the far right-hand bar, the 9 days to add the next 1,000, that is new from the prior week. And then on the right-hand side, the THA Knoxville district, the last two, the 5 and the 5, those are new from the prior week. So it really shows that we're kind of steadily at the same pace of diagnosis in the county has been our maximum. And then in the district, our maximum was it was taking us 3 days at one point to add 1,000. Now it's taking us between 4 and 5 days. Next slide, please. So I had pointed out last week that Knox County had its most cases diagnosed in a week at that 935. Our most recent week was 818. We'll talk about in a minute what's potentially driving that. and there is concern that some of that may be testing volume. You see on the right-hand side, I guess we're at the 23rd of September, and it looks like September will be a significantly higher month from a cases diagnosed than July or August by the time the month has ended. The district, again, this slide, the district tends to show the same trends, just a little bit more muted than what we've seen here recently in Knox County. Next slide, please. So this I showed you last week, and so it's worth looking at again. This is the age breakdown. And again, good news, not seeing a lot of activity or change in the 0 to 10-year-old age group. The drop that we see is really being driven by the 11 to 20 age group. So I think as you see that 11 to 20, that final bar and the degree at which it dropped, if you could go to my prior slide, please. That drop really correlates with that drop from 935 to 818. But again, based on what we've seen in terms of age demographics of testing, and then what I think we've potentially heard is that we're not sure if that drop is a real drop or if it's related to a decrease in testing in that age group from last week to this week. So next slide, please. And then as I pointed out, the thing we'll be watching for on this slide is to what extent those peaks cascade to the 31 and over age group. The idea behind that is that would potentially take longer just because you've got a young person who then is exposed to a person 31 or over. And so we'll be watching that very closely, I think, over the next 2 to 3 weeks to see whether that progresses into that bottom row or if it stays in that top row. Next slide, please. So this gets back to that I showed this last week, is that overall the testing volume is fairly steady. Again, I don't know what exactly has happened to the testing volume in the 11 to 20 and 21 to 30. Dr. Buchanan, you may have quoted a 14-day average on the positivity rate. For what we drew from TDH, we've gone from a 12.6 to a 10.3% on a 7-day average. So a little bit of a difference in that data, but the trend is similar. So still not, at least on the 7-day average, not close to that 7-8%, and certainly not that 2-3% that we were before what I'll call the July spike. Next slide, please. This shows the counties or the population centers that I always show you. I think one point about Davidson is that they're starting to do a little bit more opening back up, and so we'll have to see what happens with them. Also notable, Hamilton, which is probably in terms of the similarity of a population region, is the most similar to us. At this point, they're really at about half of our case levels. Again, also, I don't know their age demographics or what's driving that specifically, but you see we're at kind of 800-900, and they've been at the 300-400 range. Next slide, please. Then hospitalizations. This is new hospitalizations each week. Knox County has been level over the last few weeks. The district, though, you see that 34, 43, 52, 59. We feel that the district probably does represent a broader age population of those being infected than what we're seeing just in the last few weeks in Knox County. And so the idea would be that it's more likely that those could translate into hospitalizations quicker. Again, the way that if we have a younger population in Knox County being infected, then it has to go through one more iteration of a contact to an older person. They have to get sick, and then it has to play out 2 weeks before that would potentially translate into a hospitalization. On the right, you see that in September, we've already exceeded new hospitalizations for August in Knox County, and the district it's unclear to see exactly where it's going to compare September to August quite yet. Next slide, please. So this is what we always show you. This is the number of patients in the hospital across the district at any one time. I'll note that the line, that horizontal line at the very end by the 108, that is truly that there's been precisely 108 patients for the last 4 days, assuming there's not been reporting issues or lack of reporting. Next slide, please. And so this just shows the projections that we had based on the overall trend from our September 9 trend line, September 16, and today's trend line. And so as we've always said, this is going to fluctuate week to week, but generally in terms of which way the wind is blowing, it's projecting out in this 100 to 150 range by really October 17th or so. And then next slide, which I believe is my final of this. Please back one slide, please. And so as far as the hospitals and their capacity, there was a specific number that the hospitals during the rise decided to go to yellow. And of course, you see what the rate of rise was. And I believe that number was in the 70 to 80 range. And so we've not been back to that number. And so part of this is the attempt to be consistent. The other thing I'll show you in the later presentation is that, and we kind of see it here, is that you go up a whole lot faster than you go down. And so you have to build in a little bit of cushion, if you will, for the next spike. Simply because once you go up, it's going to take a significant period of time to come down. But mostly it's simply that if there was a number that we changed to yellow on the way up, then it would seem to be consistent. It would be a comparable number that we would flip to green on the way down, and we've not reached that number yet. And so then next slide, and my final slide. So third highest week of case growth since the beginning. Again, last week was our biggest week. The big change is that 11 to 20 age group is less on new positive cases, but I think there is generally some concern that's attributable to decline in testing volume. We'll hear from our other partners during this meeting. Positivity rate remains above all recommended thresholds since August 30, and stable test volume since August 2. And I'm going to talk a little more about those two parameters in my later presentation. And then district hospitals in the THA district, the Knoxville district, are growing significantly. Knox County, in terms of new hospitalizations being added, remain level and manageable. And just remember, a hospital census is a lot of factors play into that. That's how many are admitted, how long they stay, with younger patients potentially not staying as long, and also deaths. All those are factors that go into a hospital census related to COVID-19 or for anything on any given day. So Dr. Gocher, that closes my presentation. I'll be happy to answer any questions.
Thank you. Are there questions for Dr. Shamiya? Dr. Shamiya, I have a question having to do with the decreased testing, especially in the 11 to 20 age group. Is that due to sort of a logistical problem where we have people willing to be tested, but they are not, it's not as easily accessible to them? Or are these people who are sort of ducking the testing so that they won't be quarantined?
So that's the specific answer to your question would be speculative on my part. We have seen in our own testing volume, we were tracking really very specifically an 18 to 21-year-old age group, and not knowing whether they were a UT student or whoever else they were. We were testing not just that age group, but we were tracking lots of different age groups, and we've seen a significant decline in the number of tests we're doing on that 18 to 21-year-old age group. That doesn't mean they're not being tested elsewhere. And again, I look to see what our partners from the campus have to tell us during this call as well. But the specific answer is there is no reason to think that there are barriers to getting that test done.
And Dr. Coacher, I would chime in from our side and doing interviews and talking to families. We're being told by some parents that people are intentionally not getting their children tested and not willing to do that. So,
And hearing the same thing from the university side as well.
and as Charity said, hearing the same thing from the university side. So we are getting verbally told that by citizens.
Thank you. Any other points of discussion on Dr. Shamia's first talk this evening? If not, James, thank you very much. Really good information this evening. Next on the agenda are our educational institution presentations, and we'll start with the University of Tennessee. So Dr. Gregg, are you the presenter today?
Yes, sir, I am.
Great to have you. Thank you for your information.
Well, thank you. It's good to be with you this evening. Dr. Plowman has asked that I speak to you on behalf of the university, and I'm happy to do so. I'd first like to start with our most recent data, then update you on our broader testing strategy for the campus, and then finally make you aware of research that we're involved with pertaining COVID-19 and recommendations regarding the duration of quarantine. So first, we'll review our campus on data. You can place the first graph up now. This first graphic reviews our current active case counts and recoveries. As of today, we have 132 active COVID-19 cases. 124 of those are students who've tested positive, and 8 are employees. We also have had 42 new recoveries reported since yesterday, which brings our total recoveries on campus to 1,264 since the 8th of June. Next slide. So this graphic shows or represents the total number of individuals currently in quarantine and isolation. We have a total of 685 now in quarantine and isolation. 625 of those are students and 60 are employees. From these graphs, you can see that we've experienced a significant drop in active cases over the past couple of weeks, which could be viewed in one of two ways. First, it could be reflective of overall recovery and less new active cases, which would obviously be a good thing, and we're certainly hopeful that that's the case. We know we have a number of UT students, faculty, and staff that are to be commended on their efforts focused on supporting that very outcome. However, based on the precipitous drop in the number of individuals self-reporting as testing positive on our self-isolation forums, the lack of testing that's being requested by students through the Student Health Center now, and when compared to recent prior weeks, the decreased number of college-aged individuals now being tested regionally, our concern is this is more reflective of fewer individuals electing to be tested overall. We expect that as we move forward with our systematic testing across the campus, we'll begin to see the number of active cases on campus rising again. So I'd like to talk to you about what our systematic testing across the campus will look like. Last week, we began that testing with wastewater testing. Our labs found traces of the virus at some of our residence hall facilities. And this was expected because we know that some students are isolating in place in some of those facilities. And because we know that there is evidence that previously infected individuals can continue to shed the virus gastrointestinally even after they've recovered and are no longer considered to be infectious. Our wastewater testing will be ongoing throughout the remainder of the semester and provides us a baseline and the opportunity to spot trends either up or down, indicating where we may need to focus our resources. We've also started pooled saliva testing at some residence halls. The pooled saliva testing allows us to estimate what percentage of residents there are positive for the disease. These results will allow our team at the Student Health Center to know who needs further diagnostic testing with a provider-obtained nasal swab PCR test. Taken together, results from this comprehensive strategy, wastewater testing, pooled saliva testing, nasal swab PCR testing, and our contact tracing efforts on campus. This should help us to better understand and manage the health of our university community. And finally, I wanted to make you aware of a research study that we're working on with the University of Kentucky. We will be asking our students that are in quarantine to participate in this study, and it will include nasal swab testing on days 3, 5, 7, 10, and 14 of their quarantine period. The hope is to better narrow down the window from exposure that we know individuals can potentially test positive for the disease. This study is what Dr. Burks from the White House Task Force had asked us to take on during her visit. We hope with this data we could better inform CDC guidelines around quarantine and hopefully result in limiting the overall number of days for the quarantine period, which presently stands at 14, which you're aware of. So I thank you for allowing me to present this information to you this evening, and I'm happy to answer any questions that you may have.
So, Dr. Gocher, I had a question.
Sure.
So, Dr. Gregg, I don't know if it's possible for us to project again the original graph of the active cases. I don't know who's running the presentation.
We're on
I
it.
think that was
On it. Okay. And so you've essentially mentioned this, but I just wanted to kind of make the point. If we can get to that, yeah. Thank you, guys. The slide before that, please. So I mean that's so this is active cases. This is not the number of new diagnoses a day, but that's absolutely a dramatic decline.
yes.
And I'm going to kind of state this and ask it all at once, but based on everything that I understand about COVID-19, in knowing what was in effect or what changed, there is nothing that I can really say to explain that type of decline in active cases other than a decrease in testing. And in my presentation coming up, one of the points I'm going to make is not just from a college standpoint, but from a societal perspective, the importance of testing. But to me, that just very much states that they just were not as many people being tested because there's nothing else to explain it to go down that fast in that environment. And so I know that you have concern about that, but would you have any other explanation for a decline like that other than a decrease in testing?
I do not. I would agree that our concern, the optimistic side of me wants to say that it could reflect a good thing, but just looking at other data points that we do follow, looking at the number of people that are self-reporting as having tested positive, which typically on our self-isolation forms, that means that they went somewhere else other than the student health center and were tested and the results were positive. So we've seen a decline in the number of those during this period. And then just from the student health center alone, we were doing 50 to 60 tests a day. And over the past week or so, we've seen a precipitous decline, even only doing one test on one day, which is just not reflective of what we would think would be happening on campus. I can tell you that even from the student health center standpoint, we're even seeing fewer patients with any type of respiratory complaints. And I'm just concerned that the driver behind that is that the concern is if they present to the student health center with any type of respiratory complaint, then obviously the recommendation is going to be that during this time frame, they certainly should be tested for COVID-19. And there's just not a desire to be tested at this point. We certainly have the capacity to do it, but we're just not being called upon by students to do it at this point. So I think those are the things that make me most concerned, that it's just a reluctance to be tested, which to me would be more of a concern that people are wanting to avoid the potential for isolation if they're positive, and then quarantine of their family or friends if they're positive.
Thank you. And just a follow-up question. So on the, for example, the saliva, the pooled testing. So if a pool is positive, then I guess I'm just trying to get a sense from a reporting standpoint about how this is going to then reflect on our numbers. If a pooled, and Dr. Buchanan, you can chime in on this as well, but if a pooled saliva specimen is positive, then does that mean that the specific people then are tested to determine how many positives there were? And the same with wastewater, that leads to very specific testing. So we know, did that pool or the wastewater reflect 1, 2, 5, 10, 20 cases? Is that how that's going to work?
Yes, essentially, the initial idea behind all this was to kind of narrow in our spectrum of having the number of people that we had to test, because as you recall, back in March, there was limited availability of testing.
Right.
And so as we started this down this path, our goal was to try to hone in on the number of people that actually truly needed to be tested. So the wastewater testing, originally we'd planned for it to drive our saliva testing. So if a facility tested positive on wastewater, then that's where we would focus our pooled saliva testing, get those pooled saliva groups that tested positive, and then perform PCR testing on them. So that was the way that we had originally planned. Because of this surge in the number of positive cases that we saw on campus previously, and involvement of our epidemiologists on campus and our researchers there, we pivoted on how we plan to proceed. And at this point, we will continue to do wastewater testing on a routine basis on every residential facility on campus, mainly utilizing it as a means of spotting either up or down trends and indicating where we may need to focus our next testing effort. Then our pooled saliva testing will be used more as we'd originally planned, and that's to focus in on an entire facility where everyone is required to participate in the pooled saliva sampling. And then we hone down on the groups of individuals within that facility who are testing in a positive pool, determining who is most likely to be positive, and then referring those individuals to the Student Health Center for nasal swab testing.
Okay, very good. Thank you.
Thank you, Dr. Gregg. Any other questions or comments on Dr. Gregg's presentation?
Dr. Gregg, quick question. You talked about the research study that you're doing. Any potential that you would expand that outside the university for other folks who are in quarantine?
Well, I know the greater,
other age groups, yeah.
Yeah, I know that the greater number of researchers always like bigger numbers, right? So that would be ideal. I don't know that, I know the University of Kentucky has individuals, a broad range of age groups of individuals that are participating. At UT, we're somewhat limited as the only people that we actually have access to for testing are the students that are in quarantine. But if you were to have access to others whereby numbers could be presented, I suspect that would be welcomed. So I can certainly put the health department in touch with Dr. Crawford, who is overseeing our testing efforts, and let the two of you discuss that further. I think that would be an awesome thought.
Okay, thank you.
Any other comments, questions? If not, Dr. Gregg, thank you again for a really good presentation on what's going on at UT. Next on the educational institution presentations will be Knox County Schools. So Ms. Wagner, if you have your presentation ready, we would like to hear from you.
It's on its, there it is.
Okay. Next slide, I guess.
Hold on, we're having a challenge. It's a, yeah.
Okay, just like last week, these cases are from September 16th through yesterday. But today's cases are the number of active students is 45, staff is 13, which totals 58. Next slide, please. And this gives you a different view of the number of students and the number of staff that are active. Next slide, please. So from September the 16th through the 22nd, we have 126 students that were recovered, 97 and 223 recovered total. Next slide, please. And this just gives you another view of those recovered. So, you know, you have the students on top and then you have the staff on the bottom in the dark blue. Next slide. So this is, like I said, this is from September the 16th through the 22nd. But today's numbers are for students is 1,004. For staff is 91, which totals 1095. Next slide. And this just gives you a different view of those in isolation or quarantine for students versus students and staff. Next slide. And this is how we figure if the school goes red, or we look at student attendance, teacher and school staff attendance, bus service interruption, etc. And substitute availability remains in the red, but we are working on that. Next slide. This slide here just tells you what the different colors mean. Green is go, yellow is, you know, slow down, or in red is stop. Next slide, please. So House High School went red this past Monday and will return on Monday, October 5th, unless otherwise notified. And the decision was based in consultation with Dr. Buchanan at the health department. And so the goal was made to help reduce the spread of COVID-19. And so these students that at House High School will participate in online learning until October the 5th. And that's the end of my presentation, I think. I'm pretty sure it is.
Thank you, Ms. Wagner. Questions, comments on the Knox County school data?
Sorry, yeah. I have a couple of questions. I'm going to ask Jerry to share the slides again and go back up to the first slide that shows the cases. Yeah, that one.
Uh-huh.
So, and this is a question that we've gotten from the public, and you probably have gotten it also, Lisa.
Yes.
So your total, and I'm just going to go on the data that's here, not what's totally current. So your total active cases is only 44. However, you have 979 people in quarantine.
Yes.
So that's a really significant difference. And or isolation or quarantine, but so 40 of those are isolation, and the rest of them are quarantine. I've talked to my staff about it. I'm sure you're aware of this, but when you look at that, that's pretty surprising. But what we see in school age cases with them back in school, they just have so many more contacts. If you get one case on a ball team, there's a lot of contact. There potentially can be a lot of contacts with that. And a case in a class there, again, the schools are spreading kids out and doing what they can. I think the other important piece there is that even if everybody's in a mask, if they're less than 6 feet apart for more than 15 minutes, the Tennessee Department of Health still considers that an exposure, because the mask does not eliminate risk, it just reduces risk. In addition to that, we all know that people don't always wear masks properly. So that's a challenging message to carry to parents and to students. But it is something that we continue to watch. But I looked at, I think, Hamilton County, and they didn't have as many cases as y'all do, but similar ratio to quarantine and cases. The quarantines were much higher. It's just attested to the contacts of those students.
And can I chime in a little
Sure.
bit, Dr. B? This is Charity. I can't show my face because I'm sharing my screen, but I don't think. But I think and a testament to Lisa's team that's working with our team over there. Just so folks know, we are doing everything we can to limit the number of people that have to quarantine based on the guidelines that are there. So I'm looking at seating charts there. If there's, and like Dr. Buchanan said, there's, students going to multiple classes. So you have to look in, there's potential for exposures at all of those, and after school activities on the bus, they're going to, when there's cameras available, they're looking at those on the bus to see who is sitting around the children and all of those things. But the goal is to have it be as limit disruption as much as possible. And while the numbers may seem high, they really are doing a very good job of getting truly the kids that fall into that close contact definition identified, and teachers and staff as well, and acting on those. And Lisa can chime in, but I just wanted to speak to the work that the team there is doing and that our team is doing when speaking, with interviewing parents and cases and everybody to get the full picture of making those decisions.
Thank you. Dr. B is right, and Charity, that parents, some parents, most of them, they really don't understand they think that just wearing a mask, that should cover it, but the distance is what matters. And so they have a hard time understanding that. So we've been trying to really educate them on that, but some of them really have a hard time with it.
Well, it's not limited to parents. It's a tough, they're like, I'm doing everything you told me to do, and I still get counted as a contact. So and we continue to struggle with that outside schools as well. But that's we're following the guidance of the Tennessee Department of Health on that call.
Any questions on my presentation?
Any other discussion or questions for Ms. Wagner? If not, Lisa, thank you very much for your report this week. And the next item, if we have no further discussion on that, on educational presentation, the next item on the agenda is number 10, which is Dr. Shamia's discussion of potential metrics. So Dr. Shamia, if your slides are ready, you have.
Thank you. Yeah, thank you. And if we could, I'd like to make a few comments before we flip over to my slides. And that is that, first of all, this is really just a first formal attempt to try to take some of the specific concepts and numbers that can be looked at to try to base decisions upon. And a few introductory comments before I get into the details. The first is that I don't do all this myself. There are people that are helping me take the time to prepare, but we did do some research in terms of how other people have structured this. And just to give you an example, West Virginia as a state, not as any particular county, and I know it shouldn't matter, but a Republican-led state. And what they've done is they've taken some of the things that we're going to look at conceptually at the level of particular counties. And to the point that they're even saying whether a county can have high school sports or not based on certain of these types of metrics. I'm not saying that's right or wrong. And, as I said, they've approached it more as a state, and that's a different state than we are. But I'm just making the point that, and that's not the only example, that there are people who've attempted to do it this way. That being said, it's nuanced and complicated, and you'll see that in a minute. And I've made it as kind of digestible as I can, but the intent today is to, at least my intent is just to give this to you so you can see it, ask questions about it. My intent was not that we make any firm decisions. We're well above any of the published thresholds to make any decisions tonight. And so really the idea was more to get this in front of you, hopefully can generate some discussion, maybe bring it back next week. But there's enough here that I don't think it's the type of thing that we would just one and done it tonight. So with that being said, I'll try to guide you guys through this to the best of my ability so we can flip over to my slides. So, so here, what would be the goals of establishing community metrics? And again, let me make this clear. We have a red, yellow, green system. We have benchmarks. So it's not like we don't have anything, but I think that there has been the desire to have more concrete, specific numbers, if you will, to try to make decisions based upon. So this is an attempt to do that. So what are the goals of that? Inform the public, set expectations, and provide stability, create a standard for the current situation, provide context to individual data points that are changing, encourage testing and mitigation, meaning gives you something to shoot for. And I'm going to really, really emphasize the importance of testing when I get to that point. Set actually goals for relaxation of mitigation policies, but also set the stage for if things were to get substantially worse, that further action would potentially need to be taken. So next slide, please. So, so this is just for the appearance of it. We're not going to stop here, but we're over the next 8 slides. We're going to go in more detail over these 4 quadrants. There's no getting around that this is complicated. And I honestly feel, though, that anyone who would consider making decisions based on cutoffs needs to make sure that they understand the significance of these four quadrants, these 4 graphs. Now, the good news is that we've been talking about kind of portions of this the entire time, but this is largely the way any written document about controlling COVID-19, controlling the pandemic, frames it into these concepts. Next slide, please. So now we're just going to break these down one by one, really with 2 slides each, and I'll kind of refer to my notes as I go. So the easiest one to put our arms around without question would be new cases. And by the way, if I need to say that if we were going to take this approach, and I'm not saying that we need to, but if we did, we could adopt 2 of these, 3 of these, 4 of these. This is just things to consider. So it doesn't have to be everything. But I think on the other hand, if conceptually we don't understand the importance of all 4 of these, and we can't communicate to the public and to anyone who's interested in having accountability for this issue, then we've missed the boat. That understanding these 4 is critical. So new cases, this one's pretty straightforward. The number of new cases identified as documented by what I would propose is the Tennessee Department of Health. It shows growth. It shows whether we're stable. It shows whether we're declining in the virus spread within the county, assuming testing volumes are adequate. And that's why I'll talk about testing volumes. It needs to be considered as a proportion of population. So anywhere you look at this, it's in terms of per 100,000 residents. And I'll show you on the graph in a minute. And more than one source, there are acceptable and unacceptable levels offered by the Harvard Global Health Institute, offered by the White House Task Force, and the Tennessee Department of Health. And those levels, although they're not necessarily the exact same, they're generally in the same range across those different recommendations from those different groups. Next slide, please. So as we look at this, again, it's going to be number of new cases per 100,000. And you see our data day by day where we've been, and then the various different levels. And so to put this in a little bit of context, between 5 and 10 per 100,000, you're considered to be in a state of community spread. If you're between 10 and 25 per 100,000, that's considered a more serious outbreak condition. If you're over 25 briefly, then that implies some degree of trouble. And if you're consistently over 25, then the recommendations would be that you're moving toward more of a stay-at-home order. And again, this is not intended to be, I'm not proposing that. I'm not trying to be controversial. I'm just giving what has been asked for by a variety of sources, which is how could we use metrics to try to make decisions. And so, you know, I think that it would be hard to have a framework that wasn't looking at new cases per 100,000. And you see that, you know, at least here as of late, until we had this very most recent decline, which may be related to some extent to testing, we've been in that kind of between 20 to 25 or greater than 25, really in that 20 to 25 range per 100,000. Next slide, please. Okay, now we're going to spend a minute on testing volume. And I'll kind of go through the slide and then I've got some additional comments. So what testing volume does is it indicates how well test results represent the county as a population. The more tests, the better. In a perfect scenario, we would be doing tests from a random sample of population, but clearly that's not what we're doing and not practical. And that's the other thing about this that we know over and over is that sometimes practical wins. Now, there's also going to be a margin of error in what we do, meaning that if the bigger the sample you're getting, the more confident you are that it represents the population. So now let me kind of talk more bread and butter conceptually what this really means, because I think this one, its importance is potentially the hardest to understand. If you're not driving testing, you become less and less confident of how much COVID-19 you really have in the community. And that gets back to our conversation about the campus. You also become less and less effective at controlling the spread through contact tracing and quarantine. And so if you're not driving testing, this is how you can set yourself up for an unpleasant and abrupt surprise. You really don't know what is going on. And so as much as the concept of if you don't test, you don't have as many cases and you kind of can close your eyes and look the other way, that works for a few weeks, but it really comes back to bite you after a period of time from a community level. Next slide, please. So essentially, and I don't want to get too far in the statistical weeds here, but the more testing you do, the narrower the range is of what the real population may be. And so just to kind of throw a number, a nice round number out there, if you're doing below, and I open this to Dr. Buchanan or to anyone else as we get into discussion, but if you are consistently below 1,000 tests per day, you really don't know what's going on. You really don't have a good sense of where you are from a COVID perspective in the community. And if anyone can't really put their arms around the importance of testing, then they really don't understand control of a pandemic or COVID-19. So next slide, please. So now the positivity rate, and I put this in order because the positivity rate is the natural consequence of cases and the amount of testing you do. It's the ratio of positive tests to total tests conducted. And in a perfect scenario, it gives an assessment of how large the set of active cases is in the population. Because in reality, we know, there's no getting around this, the people we test are more likely to be positive than if you were just truly randomly sampling the population. And then we also know that there's some people who are not tested that are positive. And so this is the key metric for the White House Task Force and the World Health Organization, We have talked a little bit about how we're not sure we're capturing all of the negative results, but from a trending perspective and from an absolute perspective, I still think there's a value here. So next slide, please. So then this shows our positivity rate over time, and it gives you the three thresholds: 3%, 5%, and 10%. And you kind of see both when we were at kind of shut down over toward the left and then over toward the right. Realize though that positivity rate, if you're not doing much testing, then you're going to inherently, each positive test you have is going to count more in your positivity rate. So to have a low positivity rate, you got to test. And so this is how it all kind of comes together and it all makes sense. But it's still, there's still value from an education perspective to look at testing independently, to look at case positivity independently, and then look at the ratio. And so, for example, to give you a framework, the White House says 10% would be in their red zone. And they also, the White House Task Force wants you to be at 3% to really start opening up again. And, you know, that we have to be careful that if we can't, just because we don't like the answer doesn't mean we shouldn't ask the question. Now, I do think, quite frankly and realistically, getting below 3% may seem like an unreasonable ask. But to try to maintain positivity rate under 5% for a period of time, it would be a good goal. And then the whole idea about how you approach mitigation and relaxation and increase is you relax something and then you don't relax something else the next day, because you have to give it a period of time. A few weeks later, you see whether what you relaxed had an impact or not. Now, again, when you don't test and you don't know what's going on, you may end up 2 or 3 weeks later with a big surprise. Next slide, please. And then this final one, thankfully, will be the easiest to go through because we've been looking at it and it makes sense. And that's just to look at some marker of hospitalization. We know that Knox County hospitals serve more than just Knox County patients. It is an indicator of health system capacity. It is probably a better indicator of severity than just hospitalizations because sick patients stay longer and they'll have more of an impact on a hospital census or on a system census. And probably as opposed to deaths is also a better indicator of strain on healthcare. Now, the key to this, and I've said this over and over, is this is about, this is a huge lagging indicator. It's a signifier that the situation has already changed, not that the situation will change. Everything that we've looked at up to now is an indicator that the situation will change. This tells you that it already has. Next slide, please. So the point that I alluded to earlier that I kind of would want to make here, and could you click one more time? I think I may have something that pops up. Yeah, thank you. And so here, this gets to the point that I said about how long it takes to rise and then how long it takes to fall. And so you see where we went from July 14th to July 28th. We went from that kind of 100 range to about 170, 180 patients. And then we've come down, but we're just ever slowly coming down. And I know at our hospital in the last few days, we've started to see an increase, and we're not sure yet if there's any real significance to that or not. But the point of this from, again, this is a very lagging indicator and it's got a long tail. And so the idea is that you may have not come down from your first spike before you potentially incur another spike. And so next slide, please. And this is, I believe, my final slide. And so then how do you think about some of these things? Well, we know an incubation period has been assumed to be 10 to 14 days. And Dr. Buchanan and Knox County Health Department have talked about 2 incubation periods to be the period of time where you can get a sense of whether a situation is changing based on something that happened. We also know that hospitalizations are quite variable, but they can be longer, but most hospitalizations are in that range. And another thing to think about is what's the impact of a super spreader event? And so if you have an event, and let's say that 25 people are infected, those 25 people really they don't necessarily affect your stats in a material way. It's the people that they subsequently infect. So those 25 may end up with a total of 80. That's where you start to see the statistical impact, but that takes even longer. And most importantly, you just can't get hung up on daily statistics because there's too many issues day to day, a lag in reporting, then all the cases get reported the next day. So you have to look at these things over a period of time. And so if we could just kind of, I'm sure we may need the slides for questions, but Dr. Gocher, this is just an attempt to try to just see what a framework might look like, and also to put these numbers in real context for some of what we have already seen. And so I'd be happy for discussion or questions at this point.
Thank you, Dr. Shamiya. Are there questions, comments on the presentation?
I have a quick question. Thanks, Dr. Shamiya. This is really in line with what my staff and I had been talking about using to look at how do we lift restrictions. I do have one question. On your early slide, you said that we would look at cases based on Tennessee Department of Health data as opposed to Knox County data. I know it's sometimes slightly different, but I was just curious about that.
Well, we've at times seen more than a slight difference. And we are, have been consistently kind of in what I've been preparing, use that Tennessee Department of Health data. We could certainly, if we got serious about doing this, we could, I could come back with a little better sense of the pros and cons, and you could as well. And we could, we could kind of land at a point that the board was comfortable with. That's just consistently what we've been using and what we're more comfortable with. It's still not, to be clear, it is Knox County data. It's just the data that has made its way through the Department of Health.
Okay. Charity, do you want to speak to that at all? I mean,
yeah, there are differences. One of the ways, usually our numbers for new cases are probably, from what we've seen, the more accurate numbers from day to day. That's where duplicates have been cleaned out for the most part as best we can, those types of situations. But we also know that sometimes there can be discrepancies there, especially when there's been large data dumps and cleaning up of data from the state when things are getting moved from jurisdiction to jurisdiction and that kind of thing.
Right.
But in general, probably whereas the state's got a different picture definitely on their denominator of the testing, in general, our new cases are probably the more accurate number most of the time. But I don't think on that point, there has been differences, but I don't think those numbers change as dramatically as what you see on the denominator for, and I might be wrong, but on the denominator side for the amount of testing. And there are dramatic differences there in that, and we talked about this a lot before, that we only are counting ones that we have a known patient address for, whereas there's a little bit more parameters for how the state populates that version or that portion of the data. So, but we can talk about it again between teams, and our EPIs, they can speak to it way better than I can, and your folks as well, to figure out where we want to land. I think wherever we land, we just need to be consistent with the data that we're using. So
Yeah.
Either way is probably fine to show trending data, but just to give that perspective there.
Yeah, I would agree with your point about being, the consistency is just, and you guys are closer to it on a day-to-day operational basis than I am. But whatever, once we're at peace, if we go down this path and we're at peace with what we decide, then it's just about being consistent at that point.
And then the only other thing, Dr. Gocher, you had asked a couple of times about what Williamson County used to decide to lift their mask mandate. And as far as we can tell, there was no data. It was not a data-driven decision. So I'm not sure what drove the decision, but it wasn't data.
That's from the information we've been able to gather.
Yeah, that's from the information we've been able to gather. So
Thank you for investigating that. Any other questions, discussion on Dr. Shamia's metrics discussion?
Just a really quick question. Thanks, Dr. Shmee. I think that's a great starting point for us to start looking at some metrics. And I don't know if this is a question for Dr. Buchanan or anyone else that can chime in. I know that we've had the discussion about, Williamson County as well as with some of the metrics used in West Virginia. Do we know if any of our other metropolitan counties in Tennessee have looked at similar scales or metrics, or do we have any idea?
And I'll try to answer that. The short answer is no. I have looked at their websites and don't really see any definite metrics attached to their plans. They're obviously reporting out data. They have benchmarks like we do, but no, when we hit this mark, we're going to do that. But we actually have a state call tomorrow, and the metros usually are on there, so we can actually ask them that question. Charity, we'll make sure we remember to ask.
Okay, yeah, because that'd be good to just kind of weigh in and see if we can be consistent with them as well. Yeah, thanks.
I will say the Tennessee Pledge doesn't have any metrics attached to it at all.
Yeah, and I would echo that. I think it's important that, as we've said, that anybody who is seriously kind of thinking through this has really dug into the Tennessee Pledge and knows what's there and what's not, but it is not a metric-driven decision-making document.
Other discussion? Dr. Shamiya, that's a really great start, a great swing at this, and really appreciate your efforts on it. And I guess as we hone this a little further, we can look at those 4 metrics in greater detail. We would hope that we could do that over the next weeks of time.
Dr. Gocher, I would like to ask, does this give anybody fundamentally any heartburn?
I think we've been looking at these metrics, maybe not in great detail, but certainly we've been watching these week by week. These interlace, I think, very well with our benchmarks, in many instances. So we've been watching this, but this gives at least some basis of information for what do you look for to start relaxing restrictions and opening up the community. And I think everybody, in the community would like to know the answer to that. And this at least gives something we can start to hang our head on. It's really very welcome.
Can I just add, maybe the only other thing to consider adding into that, whether we would relax or add additional measures is the progression of a vaccine. And I don't think there's a metric that we can actually do with that. That's simply a discussion of where things are at.
One other point of discussion, and this is for our consumption, but also for public consumption. If any of the board members can give a succinct little synopsis of what herd immunity is, what it implies, what the percentage of people who have either been positive or had clinical disease is, basically how that works. I'm certainly familiar with it for flu, and I think it's probably the same metrics. But if we can have Dr. Buchanan, Dr. Shamia, Dr. Sousa, somebody with some background in this, give us a little information on herd immunity, kind of for our public as well as for us.
Sure, I'll take the first stab and Dr. Shamia can fill in the gaps. So herd immunity occurs when you have enough people in the population who have been vaccinated or have had a disease that if they get exposed to it, then they don't pass it on to somebody else because they don't get sick. So one of the challenges with COVID is that we don't know how long immunity lasts. If you get COVID disease, we don't know how long you're immune to it. So that's not really a possibility. So in this country, we achieve herd immunity through vaccination. And, I don't know the exact percentage of the population that needs to either be vaccinated or have natural immunity to a disease for us to achieve herd immunity. But in this country, for the most part, we achieve herd immunity through vaccination. And with COVID, we'll have to achieve herd immunity through vaccination because right now, it doesn't appear that the immunity you get from having disease is long lasting. We might learn something different, but right now it doesn't appear to be that. And Dr. Shamia, you may know off the top of your head what that percentage is. I probably should know, but.
My understanding is that it's on the order of 60 to 70% who've been infected. And, we are not anywhere close to the 60.
And we don't want to get there.
No.
I mean, that is not a solution to this problem. And again, it's not clear how long immunity lasts for COVID. And so that is really not a solution. Achieving herd immunity through vaccination is a solution, a real solution that's safe and effective and we can actually achieve once we have a vaccination.
According to, I was going to say this is Charity, the 70% was what popped in my head as the general kind of percentage, but it does depend on how infectious the disease is. I just went to Johns Hopkins on COVID and the general range for them is 50 to 90%, and they were kind of landing in the middle for what they felt for SARS-CoV. So for COVID, in that range as well.
I'd like to say that probably many of us are familiar with Sweden, which took a very laissez-faire, wanted its citizens, encouraged its citizens to take personal responsibility. And so that's what they were hoping for, was herd immunity, somewhere between 60 and 80%. And what they achieved was about 7% of immunity. And so even though a lot of citizens, yes, self-isolated or refrained from engaging in public activities, the majority of them didn't. And their economy did suffer. This is from a report written that came out of Sweden just recently. Their GDP suffered. And compared to the surrounding countries, they had 576 deaths per million, compared to surrounding countries with similar population density. Denmark had 108 deaths per million and Finland 60 deaths per million. So this idea that herd immunity is quickly achievable and beneficial hasn't panned out for the countries that have tried, again, a more laissez-faire attempt. And unfortunately, I mean, all the reports, I think their GDP went down almost 5%, and employment went up. So it just didn't pan out for them in the way they anticipated. And so now they're rethinking their policy, and like us, we're all waiting for a vaccine because that's going to be the most effective way to achieve herd immunity.
I mean, as I understand, we're still in the single-digit percentage as far as infection.
Yeah, I don't know if anyone watched the CDC, well, I guess it was the Senate briefing today, I believe. There was some question and they had the CDC director, and they're currently doing seroprevalence studies across the US. And they found that at best, most across the entire country, it's maybe 10%. Certainly some places that have higher, like probably New York City, the Boston area, but arguably we're probably in the low single digits locally.
Thanks for everybody's input on it. I think that's a very useful little sidebar of discussion for us in terms of one method of potentially opening back up. It would be very difficult, and probably, as Dr. Hurt pointed out, that the death rate might be, or hospitalization and/or death rate might be unacceptable. Any other discussion on our potential metrics this evening?
Dr. Gocher, I have a question for the group. Since there was no verbalized dissent to the approach, is the idea that everybody would think about it between now and next week, and we just maybe have a more concrete discussion next week? Would that be our next step?
I think that's a great way to proceed. To look over this and maybe do some comparisons with other metropolitan areas, because I'm assuming that all major metropolitan areas with any COVID incidents are facing these same problems, within the state and also outside. So maybe time to look and see how their metrics are measured and so forth. It's a great idea to kind of let this bench cure a little bit. Questions, discussion, any points on that? Appreciate everybody's input on that. I think that was, very valuable information, and hopefully springboard for even more concrete information. If there's no other discussion on that, we'll go to agenda item 11, which is the COVID-19 face covering regulation 2020-1 for, weekly review and discussion.
I really don't have a compliance report today. Our complaints stay about the same. Mostly people complaining about businesses who are letting people in with masks on, and sometimes complaining about other people not wearing a mask, that kind of stuff. They've slowed down, but they've kind of stabilized. And, as reported previously, no citations or fines have been issued by KPD or the Sheriff's Office or anybody from the Health Department for people not wearing masks. Certainly not the intent of this regulation.
And I just wanted to share something really quickly that I'm not sure if other folks on the Board of Health or anyone that happens to be watching the public are aware of a survey that's been conducted since I think maybe about the middle of May by the University of Tennessee through the Baker Center, as well as some of our social work folks. And basically what it is, it's a variety of questions related to COVID-19 that's been done across the entire state. And they were initially doing it every 2 weeks, and then they are doing it every month now. And so I just wanted to, I don't know if I can actually share screen. I can do that. Oh, I can. I just wanted to share 2 questions that I think are interesting with regard to not only the mask mandate in general, but also public opinion regarding mask mandates and where they trust sources. And so this is basically 2 different waves. And so you can see the date that these surveys were conducted. And again, these are across the entire state. Each wave has approximately 1,100 respondents to the survey. And about half of those respondents come from the 6 metropolitan counties. So the other half come from the other 89 counties, a mix. This is not separated out by which county is which. But this question asks specifically, what sources do you trust about the benefits of wearing a face covering? And 75% of the respondents in both the 4th and the 5th wave, and so these are the most recent surveys that they've done, said that they trusted the CDC or the health department with regard to the benefits of that. About 30 to 32% was state government, 28 to 29 was federal. Local governments were about 28 to 30. So all of those governments hung around about 30%. Employers were lower, and the news media was also lower. And so just know that it seems like the majority of people in our state actually do trust health departments to give them advice on the benefits of wearing a face covering. And then just the second question that I'll bring up is, are you supportive of a mask requirement in your local community? Again, so 4th wave is blue, 5th wave is red, and 74 to 75% of respondents said yes. that they supported a local community mask mandate. 17 to 18% said no, and 8% said they were not sure in these two waves. And so just obviously this is across the entire state and not Knox County specifically, but I think that probably gives us a reasonable picture of what most citizens across the state are thinking in terms of preventive measures that we can do fairly easily that don't actually have an economic impact. If anyone's interested, you can go to core19.utk.edu. They have this survey results on there, as well as a bunch of other information like tracking map data and policy briefs that are available. So just wanted to share that for anyone that was not aware of that resource that the university put together initially back in maybe April or May. But it's available for anyone to look at.
Thank you, Dr. Sousa. That's great information. Any other discussion on COVID-19 face covering regulation review and discussion? If not, we'll go on to other business. And anybody have any other business that we need to bring up or discuss at this point?
Yes, this is Maria. I'd like to bring up some new business.
Dr. Hurt first, thank you.
Yeah, if I can share my screen, please.
You can do it yourself. We don't have to give you permission.
Okay.
Down at the bottom.
I just want to say before I share my screen, you know, last week at the end of our meeting, Mayor Jacobs signed off by telling us that he felt for us Board of Health members that, you know, we didn't ask to be put in the position in terms of the spotlight that we are. And I genuinely and sincerely thanked him. And frankly, that's why I was shocked. Actually, I was outraged to see the Freedom Forward video that he released literally the very next day. I believe it's inappropriate. It's dangerous. It only reinforces the emails, the mails, the phone calls that we on the Board of Health get every day about being, and I'm quoting, our science is a lie. We're just trying to put deep fear into the community. We destroy people's lives. We're responsible for skyrocketing overdoses, suicides, and being told that the battle's going to continue. So when I saw this video, and I can't speak for my fellow Board of Health members, because of course we don't communicate with each other except in this forum. You know, my family, my grown children here in Knoxville begged me to start using an alarm system. My neighbors, both Republicans and Democrats, patrol my neighborhood to make sure that people aren't harassing us. So I'll let everyone else draw their own conclusions.
Truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. These words sparked a fire in the imagination of mankind. They inspired a revolution. They launched a nation nourished by the blood of patriots and built on a foundation of self-governance, freedom of choice, with liberty and justice for all. Today, this foundation is once again under attack. Not from some ominous enemy abroad, but from sinister forces within. Unelected bureaucrats who cast down edicts which carry the force of law with no accountability and no recourse. So-called experts ordained by the media who weave a web of spin, misinformation, and deceit. Violent mobs who lust to erect a socialist utopia on the ashes of the republic. And worst of all, an atmosphere of division, hatred, and fear. Conspiring to rob us of our birthright, our freedom. Thus far, the chaos engulfing the rest of the country has impacted us only marginally here in East Tennessee. We watch from afar, secure in the belief that it can't happen here, but it can happen here. It will happen here if we don't act and act now. Now is the time for a movement that champions our God-given natural rights, a movement based not on partisan politics, but on kindness, respect, and compassion, a movement worthy of the high ideals of our founding. For too long, good people have sat on the sidelines, forgetting the thing that makes America different, special, the thing that makes America great. Our freedom is only a generation away from extinction. Will this be the generation that stands up, the generation that joins up, that speaks up, that shows up? Or will it be the generation that gives up? The choice is ours for now.
I'm just going to say one quick thing. I heard about this video. I saw this video. It disturbed me. It disheartened me. It hurt. We are volunteers here. We are the people. We're part of the people. And as a military officer who has sworn to defend this country, I felt threatened by what I saw. So I'm going to stop right there, but this division has got to stop. We are in this together. We will do what we can based on science and good effort on the part of this board. And if others want to go some other way and want to do it based on shooting from the hip, so be it. You will reap what you sow.
Thank you, Dr. O'Brien. I feel the same way.
Any other discussion? I guess I can speak and say that a couple of things. We've had, I think as a result of some of the occurrences of last week, we've had a real, I think, genuine outpouring from the public that we see on our emails, and as well as personal notes and you know, discussions we have with our neighbors and friends, that it is actually not disheartening, but quite encouraging. But there's obviously a very disparate group of opinions in our community about what to do and where to go. But there wasn't, I think, within this last week, an outpouring of people who were probably on the sidelines and then decided to speak up. I'm concerned of the ability of our group to stay together, because if there is an escalation, I mean, I've personally been encouraged by a number of people to resign from the board because of safety concerns, and I'll bet you other people have been approached by friends or relatives asking them to do the same thing. And you know, as I've told a number of people, the way I was brought up and the way I've been trained is when you have a task, you complete the task. And I think that's just a good guiding principle we probably all go by. But these are interesting times, so it's still, I think, of a large task in front of us that we should seek to complete. Discussion?
My intention with that video is not to put anyone in harm's way, is not to threaten anyone. And I'm sorry if it came across like that. As I have said multiple times, and I said it in that video, the point was to try to get people to talk, to speak out, to show up at meetings, because that doesn't always happen. Maybe that didn't come across as any of us wanted it to. And for that, I do apologize. But nevertheless, I have certain responsibilities that I have to do too. And when we look at the overall picture, you know, this board, and the reason for that too, also that video is not supposed to go onto social media. It was supposed to go to a specific meeting and that went on to social media. Again, my fault. This board is looking at public health. And I've said repeatedly, you all are good people. You are volunteers. We've all been thrust into a very difficult situation. My picture that I'm looking at is bigger than public health. Public health has a huge impact on it, but it is bigger than public health. We're setting a precedent, not just you guys, this country, with what's happening with COVID-19. It's a very dangerous precedent going forward. That government overreach is completely fine. We're talking about metrics tonight that how can we even attain those? And how many months are they away? We can't spend the rest of our lives, and it feels sometimes like that's what we're doing in this situation. People cannot do that. I do apologize that if anyone felt threatened, if anyone felt as if I was launching personal attacks on you, that's not what I was doing. I do think it's dangerous that we have unelected people making these kind of decisions. But the point was, as you saw, was a movement that's based, it was to identify the problems, point out the problems in a dramatic fashion, and then to say, hey, let's start a movement. It's not based on politics, but that's based on being Americans. I apologize if that was divisive. I can't apologize for my sentiments because that's how I feel. Again, to anyone watching this, it's not the board, it's not the individual members that are an issue. It's a system which has thrust us all into this position. So, and what I said last week, what I said in my weekly update last week, it's exactly how I feel. They shouldn't be blaming you. And I'm sorry if the blame was thrown onto you. That, again, that was not the intention. So my apologies for that. They holler at my staff as well. They're yelling at everyone right now. I wish people wouldn't do that. I mean, I wish we could get through this, but unfortunately it looks like we're in it for the long haul, and I don't know how to fix that. That's my perspective. Again, to anyone out there, the people on this board are competent professionals that do a very good job. They're in a very difficult situation. Everybody is. So again, my apologies for the harm that I may have caused you.
And I just want to speak up for my staff who had very similar sentiments to the Board of Health when they also saw this video and felt concerned for their safety and for even for their positions. So just.
Yeah, again, my intention, Dr. B, was not to harm anyone. And I'm also a politician. And sometimes, you know, I have to make a political statement. That was an attempt at a political statement. I will say again, for the record, the people at the health department are doing a great job. It's very difficult. You're doing a great job, and it's very difficult. But I also think that if you weren't in the position that you were, and the people weren't in the position that they are, that we will, as the county, would be in much worse position than it is.
Mayor Jacobs, this is Diana Drake. I'd like to ask you, why do you think we would be better if we were elected to the Board of Health?
Because there's accountability then. Currently, there's nothing. I mean, all our other boards, and I'm not saying you would be better. The problem with the situation it is as it is now. And this is, Dr. Buchanan talked about this at County Commission this week. Originally, our law department had said that the public health director, who is Dr. Buchanan, is the entity, the individual who issues public health directives. That was changed to the Board of Health. And that was not our decision. That was not Dr. Buchanan's decision. That was the law department's decision. And that threw everything into confusion and chaos. And that's when we started talking about having these open meetings. That's when we started talking about having the Sunshine Law and public forum and all those things. When the Board of Health went to being an advisory committee, and you never really were. If you look at the Tennessee State Code, the powers that you all are now exercising, you have all the time. You did not gain those in an emergency. Dr. Buchanan did. But for the Board of Health, your powers are extremely broad. And no one knew this until the pandemic. In our system of government, there has to be some sort of balance and check to that. And it should be county commission. What should be happening, and I don't even agree that the county mayor should be making these rules. I think that it should go through a legislative process to where commission is able to vote on them. And then with the request, which can be done in a 48-hour period. If the Board of Health were to call and say, Mayor, Commission Chair, this is an issue. This is what we think needs to be done. We could have it done in a couple days. The way, and again, this is not the fault of the board. This is how this is all eventuated. But now everything just goes right through, and commission has no role. Other than voting on this, I have no role. That's not how our system of government is set up. And I think that we can all agree on that. And it'd be one thing if this had been a couple weeks or a month. We're 6 months into this, and there's evidently, I was watching Dr. Shamia's presentation on the metrics going forward, and we're talking about many, many more months. That's a real problem when we're thinking about our system of government, checks and balances, and all those sort of things that I have to think about. Does that answer your question, Dr. Drake?
It doesn't make me feel warm and fuzzy.
None of this is warm and fuzzy, and I wish it was. But none of it is.
We are held accountable. We're held accountable to our oaths that each of us took when we entered healthcare. Each of us took solemn oaths to protect our patients, their health and welfare. We are held accountable. We can be dismissed from the board for cause.
For cause, but that's it.
I'd like to point out that the National Association of Local Boards of Health are not aware of a single example nationwide where a Board of Health is elected. So the community feedback we keep getting about, you're not elected officials. The National Association of Local Board of Health could not identify for me one single example of a Board of Health that's elected. They're either fixed, as we are, each of us are elected by our respective professional organizations and then appointed, or they're appointed by someone.
I understand, but in this situation where this has gone on for months.
Our faces plastered on a public forum, calling us sinister forces. And I think
I was on that too, and I was not referring to you as a sinister force. I'm sorry, my apologies.
I think pitting us against, as though we are a force, aligning us with so-called health experts and pitting us against the good people. I think probably, I don't know, but I would assume everyone on this board is for free speech, civil liberties. We did not create the pandemic.
No, I understand that.
And we are doing the best we can, but pitting us the imagery against the good people who need to speak up and fight implies that there is a division, that we are not on the side of the people whose lives we are trying to protect, as well as preserve our healthcare system.
I understand that. I understand that. And my apologies for that. That was not the intention.
Doctor,
So
sorry.
I have a question that's of a legal nature, and Mr. Sanders, let me know if this is not the appropriate forum, but it may be. We know that County Commission has had a study session about changing sort of our legal abilities to perform as we are now. But my understanding, and I think Mayor Jacobs pointed this out, is that our powers are derived from Tennessee Code Annotated that dates back to 1985, probably during the HIV epidemic. And first of all, does the state Tennessee Code Annotated trump what County Commission would come up with? And my understanding of the Tennessee Pledge is that it is, and I looked over it again, it's largely suggestions. So if the Tennessee Code became or the Tennessee Pledge, excuse me, became our sort of de facto set of rules, that basically this would all be suggestions. Thoughts on that, Mr. Sanders? I guess first that first thought about who trumps what. Does the state trump the County Commission? Does the County Commission trump the state in terms of responsibility here?
That's probably the only question that's reasonable to answer in this context, because we're going to quickly delve into hypotheticals since the County Commission actually hasn't voted on anything yet. And it's further my understanding that from watching the meeting the other night, that what the County Commission discussed the other night may not be in its final form yet. But the easy answer is county cannot create a regulation or an ordinance or anything else that conflicts directly with state law. That's firmly established. The county has to remain within the parameters of state law. But as to whether anything the County Commission votes on would conflict with state law, I cannot answer that. That's purely hypothetical and speculative until we see what the County Commission finally comes up with, if anything.
Thank you.
On the note of the resolution that was brought forth by Commissioner Biggs and Ward, resolution of the Commission of Knox County regarding Knox County policies related to regulations of the Knox County Board of Health. They will be discussing it again on Monday. And I don't know if this board wants to have someone there to speak for the board. I'll be there. I'll zoom in because I'll be out of town, but I'll be there, speaking to the health department and what we do, and some things, misinformation that seems to be floating around about what we do and don't do. But I don't know if this board wants to have somebody there to speak for the board. It's just a question I brought up. I did talk to Commissioner Jay, and he's open to that if this board so chooses to have somebody represent the board.
So while I think that may, Dr. Gocher's going, but just
Go ahead, Dr. Sousa.
just briefly, while I think it would be potentially beneficial to have one of us there, I honestly don't feel safe enough to go. When you look at, there's at least about 100 people there on I guess Monday, that were, clearly not supportive of us, and I'm not willing to put myself in that position.
Understandable.
I, on the other hand, am not bothered by that. And I've dealt with worse with ISIS. So I think I would be willing to do it. I don't really wish to, but I think we need to have the availability for, the chairman to ask questions about what we do. And if that's possible, I will go if anybody wants me to.
Yeah, thank you. That's generous.
And
Again,
Dr.
up to the board.
Dr. O'Brien, if you would like to go, I will stand with you.
Thank you, Mayor. I'm okay. I'm not worried.
I know you are, but I will stand with you, and
Okay.
we will stand there together. Okay. All right.
Oh, is that a problem, Mr. Sanders?
You mean as far as open meetings?
The fact that three of us would be appearing in some way, shape, or form where we're not talking to each other, I would assume that is not a problem.
No, it's not. Sometimes entities such as the Board of Education, I know, do this. They will issue a quick public announcement that one or more members of this board may be appearing together in public at another forum. But that's it. The trick is, or not trick, it's the wrong word. What you need to do is not talk about the business of the board amongst yourselves in private. And don't discuss agenda items, but it's fully permissible for you to be addressing the county commission on issues of interest and that the county commission wishes you to address them on.
So it got,
Dr. Gocher, you're muted.
Sorry about that. I muted myself. I want to thank everybody for really, heartfelt comments and, sort of airing this out, because these are already scary times, and I think they were a little scarier over this last week. So, appreciate the comments. If there's no other business, I have one quick thing, which is optimistic.
do we need to all agree that Dr. O'Brien is going to represent us? Or, is everybody just assuming, I don't know, do we need to all agree to that? Is everybody okay with that?
Yeah.
I support him. I think he'll do a great job.
Yes, thank you.
I support him. He'll do a wonderful job.
I would be happy to go along with you. I'm on trauma call right now, and so usually the Monday after trauma call is a big mess. If for some reason it's not, I'll be happy to join you.
That sounds good. Look forward to having you there too, if you can.
Okay.
Dr. Gocher, if you're close to closing the meeting, I did have one or a couple comments
Okay.
Still on the same line. And I wanted to address something Mayor Jacobs said about the metrics discussion that I brought up just for discussion. And it's interesting, depending on your lens, how you can look at something and get a different interpretation. We had many people asking us to bring something more concrete forward as the basis to make decisions. And so that was an attempt. I can't help what the cutoffs are that are published elsewhere. And even really made a concession, for example, on the positivity rate, saying, look, they say 3%, but we're not going to get there, but maybe 5% if we can just stay below it. But the other part of that is that everybody's got to do their part. If we don't test, and that's part of the job here, is that, if we don't control using just fundamental public health principles, the spread of the disease, then we don't land where we want to land. And so honestly, the intent was that to be more of a positive, not a negative, in bringing that forward. And then the other thing is that, there is I don't know how quickly it's going to get approved with what the FDA is saying. And I don't know how many people and how quickly people are going to take this 2 vaccine shot, but I think we're going to be vaccinating people in January, if not before. And so, it is there is something. The other thing I just wanted to mention, and this is in the broader context of the conversation we had about county commission and everything else that's going on, is that, and even even back to the video a bit, is that, you know, I think science gets criticized in this because it's imperfect, because it's all moving so fast. I mean, if you go in with a heart attack and you get a stent put in, science was what brought that to pass. It just didn't evolve. They didn't go from inception to stent approval and insertion in 6 months. So, I mean, this is the environment we're in, but it's still the fundamental basis for how we need to make our decisions. And you know, we've all felt the weight of this, not just from a public health perspective. I mean, I've laid awake at night, and the first thing I thought of in the morning is the tension between public health and the economy and all these other pieces. I mean, you know, we're not just in a bubble. We think about those things. And so I would just urge anyone who is thinking about this from a decision-making perspective, is that it's already intimidating to be in a position to be trying to make these decisions if you understand it. And so to try to be put in a position to be making these decisions when you really don't have the foundation, not because there's nothing wrong that you don't understand, you just don't have the foundation to understand it. I would not want to be fundamentally in that position. But probably most importantly, what I would say is, it's all well and good to have these conversations now. And again, I'm not a politician, so I don't know how this is all going to evolve, and I'm not a lawyer either. But we've got to think about, let's just put ourselves in a position where the situation is significantly worse. Okay, because right now we've got a positivity rate, our hospital census is manageable. I think that we all have the hope, and some people have the certainty in their head that it's just impossible, it could get worse. But I don't believe that. I'm not an alarmist, I'm not anything like that, but I think there is the possibility that the overall situation, I mean, we haven't even been through this in cold weather yet. We have not dealt, I mean, generally speaking, viruses are more fastidious in cold weather. We've not even been there. And so we just, wherever all this lands, you got to make sure it's just as functional if things are bad as it is right now. Because you can't, if you unwind something, rewinding it back up is difficult to do. And that's what concerns me, because, you know, there seems to be this tension with science with a lot of people. And I mean, that's okay. Everybody can believe what they believe. But if things get worse, that's going to be a bigger deal than it is right now. Thank you.
Thanks for those comments. I had one quick thing to share with everyone. And as I said, this is a kind of a neat little note of optimism. This was a kind of a quick synopsis of an article that just came out in JAMA. And it points out that your chances of getting a COVID infection by becoming a patient in a hospital, if you are not admitted for a COVID diagnosis or COVID-related diagnosis, is very, very small. There was a study of over 9,000 patients at Brigham and Women's in Boston, and of those over 9,000 patients, about 8,300 were patients with a non-COVID diagnosis, and those patients were all carefully traced back, and 0.1%, that is one patient, could be contact traced back to exposure in a hospital, maybe, which means that the use of masks, the use of effective PPE, and fastidious care by hospital personnel make the hospital a safe environment for non-COVID diagnoses. I ran into this with a patient today who had neglected needed care because they were afraid to come to the hospital. And we certainly noted that during the first, month or so of the pandemic, there were people with chest pain that didn't come to the hospital because they were afraid. And takes a while to get this information back, but it's very heartening information. I think that the hospitals are actually a very safe place to come for a non-COVID problem. So a little bit of good optimistic news there. Any other discussions, points to go over this evening? If not, we'll accept a motion and a second for adjournment and plan on meeting in about 1 week then. And thanks everybody for your comments and your attention this evening.
Motion to adjourn.
Second.
Thank you. We'll meet next week then. Thanks, everyone.